I think there's plenty to discuss. One of my first things as we go through it is just even, I'm always amazed at even just the ethical considerations with these types of, quote unquote placebo surgeries and having people go through it. So that was thought pretty interesting stuff. But does someone kind of just summarize like the findings first and then we'll go from there? All right. So subacromial decompression versus diagnostic arthroscopy for shoulder impingement, randomized placebo surgery controlled clinical trial. So I think I was super excited to read this because I feel like this is one of those things that kind of gets like polarized on the social medias where it's like, we see this post and we're like, oh, see, surgery doesn't work. And I think people kind of just run with that. So I really appreciated reading this from just a kind of like bias check in a sense. Although obviously the results,
sort of confirmed it.
Yeah, but it's obviously there's nuance and there's gray. It's not just like with this 100% thing, but basically, so what? There was, they were able to randomize everyone. It was ages. Took some Spark notes. So they're able to take, participants age 35 to 65. The criteria for being even included in the original thing before they were randomized into the 3 groups was that they had to have subacromial pain for greater than 3 months with no response to conservative management. And then the MRI to rule out rotator cuff tears, but we'll talk about that because that was an interesting thing that I thought in terms of Steph and I were kind of discussing about how there's just so many different confounding variables, but
that they didn't mention until the very end.
But I thought they did do a good job of being very transparent about a lot of the confounding variables and the risk of bias with some of the, certain findings here. But essentially, what they're able to do was out of that group of what I think was 200 plus, they put, a 2-to-1 ratio where 2 of those subgroups were like going the surgical route and they didn't know if they were going to be getting the subacromial decompression or if they were going to be getting the just arthroscopy. And then that 1/3 was allocated to the exercise group. I was unable to download the appendix. I was searching the web for it as well. So I actually wasn't able to, I was really curious what the, individualized progressive exercise looked like. So I don't know if anyone was able to locate the appendix to understand that, but I'm always curious what the conservative management looks like. Was anyone able to find that or familiar with what that was in the study? Yeah, hit us, Nate.
I'm going to try to find a way to share it as a file for everyone.
I mean, would you be able to just kind of like overview the general sort of strategies used? Or just give us like a overview grade of, if you're like, yeah, that looks pretty legit. Or if it's like, that's kind of sus.
It seemed fairly standard. I've just pulled up phase 1 for the first 3 weeks was decrease pain, restore range of motion, improve posture. Phase 2, get full pain-free active range, restore some strength. Weeks 6 through 8, restore strength and endurance, restores normal scapulothoracic movement, and then weeks 9 through 12, re-educate neuromuscular control and improve strength. All the exercises seemed relatively simple, not a ton of really aggressive stuff.
Okay. Fair deal. And we'll chat about that. So
would you characterize it as what we see often as far as like standard operating procedure, like standard protocol?
Definitely. It was a lot of just like isometrics, band external rotation, active assisted range of motion stuff.
Okay. Right. So then the 2/3 were then like headed into the sort of, I almost interpreted it as surgical consult where they were first kind of getting the arthroscopy to even see if they were going to qualify for the study, right? So folks that had greater than a grade 2 or grade 3 rotator cuff tear were excluded. And then anyone who had a grade 2 or less were included. And they were able to then randomize from there into the 2 groups, which I thought was pretty cool. But then going forward, so what they were able to then either randomize them and perform the subacromial decompression or perform the arthroscopy. And then they had follow-ups at baseline, 3 months, 6 months, 9 and 12, I believe. Or yeah, 3, 6, where was it?
Maybe 3, 6, 9,
Yeah, 3, 6, 12, and 24 months. And they were basically using pain as the primary outcome on a 0 to 100 VAS scale. And that was the primary. So the primary comparison was between the surgical groups. The secondary comparison was between the subacromial decompression and the exercise group. And then they had secondary outcome measures were on functional outcomes, right? And so I believe what they were positing to find was that at the 24-month follow-up, there was no real significant difference between the two groups. There was a meaningful difference in general in terms of pain and function for both the subacromial decompression group as well as the, sham surgery or arthroscopy, which again, they talked about at the end, where it's one of those things where it's like, some people have claimed that even just the, that not the act of the surgery, but the therapeutic benefits of like, the pulse lavage to the joint, helping with improving some of their pain functions. But they claimed that that probably wasn't they claimed that that wasn't a sturdy claim. And so that wasn't really a good reason for denying it. And it also synced up with a prior RCT that was looking at a very similar comparison. And what else? Oh, another interesting piece here was they were asking folks in the surgical group. So in the two surgical groups, they were running to see, like, asking them if they thought that they had gotten one versus the other. And they didn't seem to find, they didn't seem to find any ability for patients to predict accurately whether they had gotten the arthroscopy versus the subacromial decompression, which I thought was helpful. But that was one of the things they kind of talked about at the end was it's hard when you're being excluded into the exercise group versus the surgical, like the inclusion criteria for the surgical group already kind of has a little bit of that, theatrical weight or bias in terms of potentially, messing with perception and outcomes. But I thought that was an interesting finding as well. But I mean, in a nutshell, that's pretty much that's like the 5-minute rundown on my part. I guess the one other piece was just in terms of people that got excluded as time went on. There was definitely, there was only 2 people from the true subacromial decompression group that ended up having to go back under to get re-operated on because of severe pain that was following during the follow-ups. And then for the arthroscopy group, there was 8 people that ended up getting re-operated on, which I thought was an interesting finding, that a higher percentage of people that got the sham ended up going and getting that secondary surgery compared to the initial group. So I think that's an interesting talking point as well. But I think that covers a lot of the rundown. So I would love to really just open this up to some open discussion in here, and then we can break out into groups as things go on.
Chris, do you want to elaborate on your comment that you just put in the chat? Or
yeah, sure. My concern with some of these the comparative studies, and I like the study a lot, but I think it always comes down to, like, let's consider if this population is just happens to be your general run-of-the-mill orthopedic clinic, right? That kind of sees anything, as compared to an athletic population that may both fit the diagnostic criteria. Would they have different outcomes to the surgery? So the homogeneity of the sample is one thing, but the true the true reflection of a societal population with population that they choose. I mean, I went to school in St. Augustine, and I'm sure that the 35 to 50-year-old population in St. Augustine is probably different than the 35 to 55-year-old population in Austin, Texas. So I don't know that makes like, oh, this population is reflective of all 35 to whatever year olds, was my first thought. And the second thought is, I mean, Quinn, they actually did a great on one of their recent podcasts talking about shoulder special tests in general, the diagnostic accuracy and validity of the test. So what is shoulder impingement? How do we define that? What does that mean? And, I mean, are we saying that shoulder impingement has to have an anatomic phenomenon to it, as in you have to have a type 3 hooked acromion, and then that's what this is? Or you just, take somebody's shoulder and you turn it into rotation and you jam it up, as high as you can and say, oh, does that hurt? Sure. Okay. Right. I mean, that's my immediate thought, is the diagnostic accuracy, because these comparative studies always assume that the diagnostic accuracy is valid, but is that the case? It was my thought.
I had a similar thought too when they mentioned later on about how they weren't necessarily sure if what they had diagnosed as impingement was actually a rotator cuff tear that they had missed on the MRI.
Right.
And that also somewhat fit with what we see clinically, as far as sometimes they're diagnosed with impingement when they go see PCP or other doctor, and they get an MRI and they have a grade 3 tear of supraspinatus or something like that. And in the long run, it doesn't hugely change treatment so much, as far as from, the progressive overload or exercise side, if they're not going to get surgery. But I had some of those similar thoughts as you, Chris, when they mentioned like, oh yeah, but by the way, later on, some people may or may not have been misdiagnosed as either rotator cuff tear, which they then fixed in a number of people, and or somebody who had the beginnings of frozen shoulder. So it's just depending on where somebody is in their injury journey, especially with something like shoulder, where there is just so many things that can come into play. If they're early on in either frozen shoulder or rotator cuff tear, that could very well mimic what the signs and symptoms are for impingement.
That's right. And the management also doesn't matter. The postoperative care would have been similar regardless of just about anything, unless you had a massive full thickness rupture of your cuff, right? Unless we're talking about crappy tissue, full thickness tear, yes, there's probably been a different, but the rehab that they went through, that Nathan walked us, I mean, that's no different. So really what we're talking about is a difference in interventions, assuming that the samples were randomized, but they were truly homogeneous in their pathology, which, I mean, that's
It's
a rabbit
almost,
hole in itself.
Yeah, I mean, it almost sounds like, so from twofold, it's like with a lot of stuff, it's almost like the flimsy beginnings, where you're building a study on flimsy assumptions, where like, how does that even affect the credibility of it as a whole, which you need to take with a grain of salt. But I think you brought up another really great point, which, we're going through Ben Cormack's little mini research course, and this was something that he was talking about, which I thought was super helpful. But yeah, like, what is the actual population of the participants, and how does that actually apply to the general population? So there's like a lot of meta-ness to consider when even appraising a study like this, which I do think is super helpful for spurring critical thinking, but there's just a lot of rabbit holes to kind of go down and tangents to kind of think about.
Yeah, I mean, and this, like you said, right, depending on how critical you want to be of the study, you could start to explore the type of studies that they investigated, what studies that they removed. For me, when I'm looking at any exploratory systematic review, meta-analysis, anything like that, I actually care just as much about the studies they threw out as the ones that they kept in, right? Because that's a whole nother rabbit hole. Well, if you're picking, right, then you're playing God, you're playing gatekeeper and saying, well, I don't want these because they don't suit my narrative. I mean, it's very easy to do that, as I'm sure you could all imagine. If, depending on your personal biases, you could probably all find studies that support what you would like. So my caution is always, I don't think that, that subacromial decompression is a bad thing. I think it probably is successful in some people. It's probably worth finding who those people are. But again, that assumes that we can identify what pathologic feature makes them. I mean, and that's a difficult thing to do. We threw it at a lot of people for a long time, notably throughout the 80s and 90s and 2000s. And now we're kind of coming out of that. But I think it's like anything, like, lateral release in the knee. This has fallen way out of favor. I get that, but it probably works for some people. And so I think we need to be careful at times with these studies, because it's too easy to say like, oh, see, I told you, it's all garbage. Do whatever you want. Right. Rehab's the best. We win. Like, I mean, that's our our immediate default. So that was just kind of my thought about it.
Yeah. Anyone else have any thoughts that jump out to them with this paper?
Just to further muddy the waters, I really thought it was interesting that they decided to include MRI diagnosed grade 1 and 2 rotator cuff tears, but exclude grade 3s. Just, adding to the discussion between, all right, I see some talk in the chat about how are we actually defining subacromial impingement? Is it truly structural, or is it, a clinical diagnosis? But I thought that that decision was interesting.
I think it's also interesting, or just to point out, they didn't actually, or I can't really find anywhere that it says subacromial impingement. So I feel like we don't have to like get on their throats for like how they define subacromial impingement, because they only say subacromial pain. So that's just throwing that out there.
Well, I do think they did a really, I mean, as best they could with this population. The design of the study, minus it being a really hard thing to measure, they really went about it very well. I think potentially what could change, we were talking about this earlier, in my mind, I feel like it's really, really hard to make really sweeping conclusions when your primary outcome measure is pain. Like if there's another way, potentially, I forget who exactly, it might have been on a PT Inquest recently. I think that's JW's voice is jumping out at me. I think he was the one who was saying how he has trouble, and I agree, at least with that he has trouble sort of with some of the sweeping conclusions, or conclusions in general, when the primary outcome is something that's so subjective. So again, then I thought to myself, okay, so what would they do in something like this if it can't be pain? Like, how do you define success of either surgery or rehab? And I know some of the easier or go-to things are things like pain or range of motion, or like return to said level of activity based on like a Tegner scale or something like that. And they did use some of that stuff as secondary, but I feel like that is, to your point, Jessica, like they didn't necessarily claim it was definitely this, and they admitted that the diagnosis, because it may have been early on for some people, could have been off, because they might have been just in the beginning of a different type of issue. But that is something that I do sometimes grapple with some research, as pain being the primary outcome measure. Does anyone else kind of commiserate with me on that one? Thanks, Jeremy.
Yeah, I mean, I'm certainly with you. I mean, pain is about as complicated of an issue to define as anything else on this planet. So
that's a different journal club.
It's a different journal club. You're right. So yeah, absolutely. The contextual factors and the nuances and the rituals associated with surgery in general. I mean, all those things, right? So if pain is your primary outcome, absolutely. And Jessica, to your point too, I was kind of looking through the paper. You're right. I mean, I think the issue is the further away that they get from a rigid diagnosis, the more likely that we could say that there was not enough of a rigidity to the methods to adequately say yes or no. Because I think more studies like this should be done, but I do think that the task becomes, I think, a foundational task of identifying which one, what pathology are we talking about? Like, I mean, yeah, if you break your leg, sure. Like we would all agree like, yep, that's broken. But when pain comes in, I think that makes it really tough for me. I mean, like what are the possible pathologies that could have been incorporated into this study? I guess is maybe a question for the group. Like what could it have been in this entire population?
Well, I mean, that hits on what you were kind of just talking about and just the epic complexities of pain, right? I mean, there's plenty of structural stuff, but on, kind of related to that, one of the things that I wanted to chime in about was just the fact that it was a 24-month, that was one of the primary outcomes they were looking at. Like, I also just wonder about things like natural history for something like subacromial shoulder pain, where like, how are the, like, I would be really curious for folks that didn't have any exercise group or any surgical consultation or surgery and where they were at in 24 months after dealing with this type of thing. Because I mean, that's something that's really interesting to me, is like, I'm not as, like, I don't know if anyone is super familiar offhand with some of the data around natural history of subacromial shoulder pain, but I imagine it's got to be somewhere within at most a year to 2 years on the long end, for things to just improve kind of over time with the wait and see method.
Well, the minimum was 3 months of pain, right? Was there an average? I didn't see. Is there any data on the participants in the group? The average
Yeah.
symptom on length of time? Because 3 months isn't very long.
It looked like the mean symptom of duration was between 18 and 22 months.
Okay. So they've been dealing with it for a little bit. But it's tough because you don't know really the history. Like we would get in a clinical setting, really dig into the things that they're doing from a physical activity standpoint, from an occupation standpoint, exercise standpoint, the things they're not doing, and those factors are lost here. And so it's just like taking a duration of pain. Oh, you've had pain this long, you're a potential candidate for this procedure. You got to kind of make it clean like that to make it a study, but you almost just like ignore these confounders that would potentially have an effect on whether this would be even a conversation to be had for somebody in the clinic.
Word. I mean, Chris, back to your point. So like, I think that would be a fun kind of game to explore, talking about potential, like, right. So you were kind of, if I understand you correctly, you were sort of asking like, let's just go down the road of what other potential, pathologies could be contributing to the pain from a structural perspective. Is that kind of what you were asking just for the fun of it?
Yeah, well, I mean, and that's just like, I wanted to say just structural, because depending on your educational dogma, right, there could be a lot of things that you would call shoulder pain. I mean, and again, and they said like subacromial shoulder pain, which means we're talking about palpation and landmarks, what I would have to assume anyway. I don't know how you would find that outside of probing the tissue to say this is where it hurts. I mean, and again, this gets into another conversation of it. Is this localized shoulder pain? Is this diffuse shoulder pain? How do they, like, what are the qualifiers of that symptom? I mean, it just makes it very difficult. And again, I think these studies are valuable, but and so back to your original question, yes, it would be like, well, let's just narrow it down to what are the possible structural issues that could go into this? Because again, if we go back to the original diagnosis of subacromial like pain, right, that the landmark hooked acromia, your type 3 acromia, that may be the one that's like, hey, you decompress that bad boy and you get good outcomes. But I was trying to look through the study. I don't know that they identified that. That could make a difference, in my opinion. So stuff like that would be my thought.
Raised hand, Katie Wood.
Hey guys, so I'm just like a PT1 up in Canada, so not a lot of like clinical experience myself, but I was just wondering what you guys think about how the meta-analysis that was published last year showing no relationship between acromiohumeral distance and subacromial pain syndrome, and how that factors into kind of this, because it feels like if you're taking, patients that you are determining to have what you think is subacromial impingement, subacromial pain, you're assuming they have a structural deficit. If it is something like, yeah, you were born with this nasty hooked acromion and there is something physically there, then it makes sense. But if you're going back to this other meta-analysis that is saying that your acromial humeral distance does not necessarily mean that, or is not necessarily the causative factor behind your pain. But this study is saying, well, we're just going to go ahead and make that space bigger and hope they get better. Just wondering what your thoughts are on that.
I mean, I'm not super familiar with that systematic review. I mean, I will always take kind of sweeping declarations with a grain of salt, because I think this paper that we're talking about kind of clarifies that, like, I don't know that we could say one way or the other definitively that it's just this like neat relationship, that it doesn't have a relationship, because I think there are, for some individuals, it might be more relevant and it might be more problematic, but maybe for a decent amount of the population, or this kind of general population that this study was trying to look at, it didn't really seem to have a strong relationship. So I don't know. For me personally, clinically, it's one of those things where when I'm broaching the conversation with patients, I'm not, well, ask me 2 years ago and I was definitely coming down like a hard O, being like, oh, you don't need any surgery ever. Like, it's all just a placebo. Like nothing matters. Where now I'm like, look, we understand that, like, no matter what, like, we should be trialing, progressive rehab for these, 12 weeks, and let's see what happens. Maybe for certain individuals, getting a surgical consultation could be appropriate, because there might be some individuals that might benefit from it. But there's a lot of evidence to suggest that we could have some good success working through conservative management, especially looking at long-term outcomes, and also weighing the patient's values about, like, if they're really dead set against not getting surgery versus if it's something that they're really keen to get. So that's sort of my personal take, but I'd be really curious to hear where other people are at with, this particular topic.
Well, I think that, Katie, that systematic review that you're referencing is super relevant, because that's kind of the foundation on which this type of surgery was founded upon, was just this assumption that there was some type of issue with the spacing. And if you change that in some way, then you would change, the thing that you're looking for. But when there's evidence to refute that, it's like, to Chris's point, this surgery might help a certain subset of the population, but it's not because of what we had thought that it was. It doesn't help them for the reason that we thought, potentially, or we need to learn how to subgroup differently. And there's a lot of stuff for the shoulder that we just kind of almost have to start over on. Like the Paul Salam, the podcast that we did with Paul, where he's like, a lot of these special tests were founded on really questionable validity techniques. So even to have a conversation about the tests, like, oh, do they measure what they're supposed to be measuring? Well, it like goes a layer even beyond that. So I think it's really relevant, because it just kind of pokes holes in why we even do these procedures in the first place. We kind of have to revisit the why.
Mm-hmm. I actually found it kind of funny, because I think it was like the week that this was published, this meta-analysis was the week that, like, I was in like first year MSK, and we were doing like Hawkins, Kennedy, and Neers tests and stuff. And so I was a little bit, that student questioning going on. So
yeah, cognitive dissonance intensifies.
Well, Katie,
yeah.
part of it is how to, or having a conversation with a patient. I think part of it, without going down like a pain science rabbit hole as well, is like using some sort of analogy or analogous situation, like it's also fairly well known that there are many people above the age of, I don't know, I can't reference the exact age, but over like 65, there's a lot of older individuals who over time have developed partial rotator cuff tears and they're asymptomatic. There's a decent amount of the population. So similarly to some other tissue issue, that could also not necessarily correlate as well with the type of acromion you have. And I feel like sometimes using an analogous story like that might be somewhat more common knowledge, to people or patients. That can help explain it without necessarily being like, well, pain's kind of complicated. And and then you know, depending on the person, you could seem really like you might lose them a little bit.
And just to go back on the pain, the duration of symptoms, looking at the averages in table 1, the standard deviations are about as big as the average, as the mean amount of months. So we're dealing with a pretty broad array of symptom duration.
Yeah.
There's probably some people that just hit that cutoff of having pain for only 3 months versus people who have had pain for multiple years.
Yeah.
Just a lot of contextual differences there within those types of groups, most likely, that aren't really accounted for here.
Well, Quinn, one thing I'd like to ask you, and again, those, I mean, this is an open question for anybody, but with a lot of these tests, right, in my opinion, the way that they work is you build some type of clinical, and I'm gonna have to say this word, and Quinn's gonna get mad at me and probably make fun of me because this is Scott Morrison's favorite word in the entire world, but a heuristic decision about what plan of attack we should take. Not, I mean, again, I think we think, well, I do these tests so that I get a diagnosis, when in my opinion, I do these tests because I've done interventions based on the findings of this whatever test that I make up, and they tend to get better when I do this intervention based on these findings. And it's a weird way to think about it, but like if I do this thing and you say ouch, then I say, well, based on the 20 patients that I've seen that I did this thing and they said ouch, I tried these other things, whether it be, you know, sit and wait. Jessica just Googled heuristic. Nice. Where they did this thing and I'm like, well, I tried range of motion with this, with them, didn't work so well. I tried isometrics, worked really well. I tried sit and wait, didn't go so well. I tried shoving medication down their throat, didn't change a thing. So it's a weird way to think about it, but then I'm using the test as a bucketing system and a stratification system, not necessarily as a diagnostic. I don't really care what that says, other than directing my treatment, if that makes sense to everybody, kind of what I'm saying. Quinn, does that make sense? I mean, even though you had the podcast, and to your point, like these special tests were flaky at best, do you still do them sometimes as a means or a direction?
Yeah, well, because they're like an asterisk sign, because I'm going to have the person move their shoulder around anyway. And these tests basically just have people move their shoulder around at various angles. So putting a label on the test and then saying that it's giving you something very specific is kind of the critique. But if what you're describing is, I use it as kind of an asterisk sign to come back to, and I can repeat it. It's a repeatable thing because we learn the test. It's like I have a mental model of this testing algorithm. So at least I can put them in the same position and we can retest this in kind of a repeatable, reliable fashion, pre and post intervention to see if we're kind of on the right track. I mean, that's kind of what we do, you know, but I don't know beyond that though.
I mean, does anybody, I guess my question would be like, does anybody have things that they do in clinic that's like, hey, when I see this thing and no, there's no label, there's no special, like, I made this damn thing up, but when I do this thing, I typically find that I do this intervention or I follow up with this, and it tends to make up, it, generally speaking, it has a favorable outcome.
Yeah, Chris, I mean, so not shoulder related, but like the thing that like just popped up in my mind in terms of probably one of the biggest patterns that I see, and again, recognizing my bias with these types of things, but, you know, for folks that are coming in with, you know, radicular symptoms and they're testing super positive for a lot of the, you know, neurodynamic testing for the lower extremity, when I see that pattern, I tend to rein back on, you know, static stretching and exposure based drills. And I do more of a like, you know, addition by subtraction, so to speak, for that particular subset, and they tend to get better. Not all the time, but, you know, for what a heuristic is, a general rule of thumb, that generally does work. So that's definitely one example I can think of where I kind of have that like pattern recognition bias of saying, all right, like I see this pattern, this generally works well, let's start there and, go from there.
Yeah.
Katie asked, how do you guys feel that patient expectations factor into that?
Factor into what exactly?
I'm not sure. Katie, do you want to
Oh,
elaborate?
so I was just thinking factor into the results in general. So if you have a patient population that comes in that has, been experiencing pain for 3+ months, and conservative management has so-called like failed them, are they going to have more faith in surgery as a way of fixing their problem and therefore experience better outcomes?
Well, this gets into a whole nother like domain of rabbit hole-ness.
So,
because I didn't want to bring it up, but like, was there any way to control what was said to these people before they got to the right? Like they all saw independent practitioners before they got here. We would all probably say something different because we're all unique individuals. We may say a different word that means something different to you. So that I think that's a genuinely great question.
Right. It also brings up the concept of a phrase that I highly dislike, and it's something that's pretty common, but that this person has failed conservative management, and it's rarely that person has failed, but that's definitely what the shape that it ends up taking for a lot of people. And essentially it's not that they have failed doing anything, it's that the treatment or service and or whatever else it was has actually failed them. So but people are told that, right? Like they're told or they see it on their doctor's note, failed to respond to conservative treatment. Okay, so that's basically like, it's your fault. So that's a huge patient expectation that is brought to the table non-verbally, but is felt by them. And there's no way you can control for that in a study. And that's not the researcher's fault at all. You can't, there's no way, unless you're not working with humans.
So I actually have a case study right now. An individual I've been working with for not currently, like not the whole time through, but off and on. He first came to me almost 2 years ago with, like anterior shoulder pain, which he had been diagnosed with shoulder impingement. And it's, we just tried sort of general, like based on what he was sensitive to, we tried general progressive resistance. We tried activity modifications, pretty standard, but trying to move the needle, get him to be reassured about some of his, beliefs that maybe weren't so helpful to him engaging in valued activities, and no change whatsoever in his symptoms. We were very transparent. I was like, look, he was like, I might try something else. I'm like, look, hey man, like this thing can have a longer, type of course where things can take a little bit to get better, but I totally respect that. Long story short, I see him like a year later. I saw that he had an appointment with me, and I'm like, what? And it was post-op. So he had gone to different PTs where they worked on different paradigms where, they did, new grad Zach would have had that individual. I'm like, oh, subacromial impingement. I just gotta, mobilize thoracic spine, open up that space, stretch the pecs, boom, we're good. So that's what they did. And that didn't do anything either. So then he ended up getting surgery, which he was bought into, and he was coming to me and still no change in his symptoms. And we worked together for like an additional 3 months. So I don't know, this is a diagnosis or a presentation that has been pretty humbling across my small 5 years in clinical practice, where I think it's a good sort of analog of like PT is one of those things where you could feel like one day you are the greatest PT on earth and you like manage the crap out of this case. And then there's certain things where it just like doesn't seem to have any real rhyme or reason, and natural history kind of just does its thing. So I don't know. Right now he's currently just not really doing much. Symptoms are a little bit settled, but the doctor keeps telling him, oh, maybe it's bursitis, but they resected his bursa and removed that. And then they gave him cortisone, but that didn't touch anything. So if it were a true bursitis, that should have had some influence on his pain, and just like nothing. So that's been a really humbling case to try and navigate, and hard too, because he was definitely like bought in and all go for the surgery. And even the, leveraging that massive contextual factor and meaning response didn't really move the needle in a meaningful way for this individual. Sorry for the tangent. I just felt it was relevant.
I think if you're in practice long enough, Zach, it's inevitable. It's inevitable, right? I mean, there's going to be something. I mean, again, I'm sure, as with most of you in here that have been in practice for a while, I could give you 10 stories that are like, I did all this stuff. I felt super good about it. Not a damn thing changed. And then this guy went next door and had like a 30-minute massage. And he comes back and he's like, my pain's totally gone. I'm like, yeah, well, screw me. Right. I mean, like, it's like, and you're like, awesome. That is fantastic. Like you're happy for the person and you're like totally disappointed in yourself. And then you realize that these are humans and they're not cars. They're like walking, talking meat suits with a bunch of electricity running through them, and stuff changes all the time. I mean, it's like, right? I don't know. They had a bad day. They felt good about it. I don't know. I mean, there's too many of those variables. And so I feel that's what I like. I genuinely feel bad when I see studies, because I'm like, it's too easy. There's so many things. What we know right now is if we can go round up, how many participants did we have here? What was the total? I can't remember. Somewhere around like 110, 105 or something like that. 110, 120.
It was
In
more.
the,
It was
surgery. Or
well. I think totally on the outcome, it was around. It was close to 200. I think
Close to 200. Okay.
210.
So if we can go round up those 200 people, the same exact 200 people, then we know exactly how this would come out. Outside of those 200 people, I don't know that we know much. How do we? Yeah, I don't know. It's just such a difficult thing. Shoulder pain is most certainly one of those issues. I mean, right? Like I said earlier, you break a bone, great. Like we know what to do with that. You come in with shoulder pain, we're like, well, I don't know. Let's like spin the wheel of death and see what you land on, and we'll make a decision, right?
So should we shift this conversation then, with all of the positives here, should we shift this to kind of like where the rubber meets the road? How does this influence practice? What are we doing with,
the conversation you have too.
Yeah, like what are the conversations that we're having, right? Because I think that's one of the big things is how we're communicating this uncertainty around it in a hopefully empowering yet realistic way, and what your treatment might look like. So I don't know if we would want to break out into groups for that and then kind of come back all together. That way we can give more people an opportunity to speak. So why don't we do that? Chris, you remind me of one of the, it's been a while, but we do some satires here and there through Level Up. And one of them is like this, hyperbole of like the nihilistic therapist that's been in the game for too long. And they're just like, it's black and white with the bangs, ripping a cigarette in the patient's face. And they're like, I have shoulder pain. What did I do? And they're like, nothing matters, man. Like, just get out of here. Do whatever you want.
And I hate to be this person because I'm like a super optimistic. I'm like naively optimistic.
No,
like, oh no, you're going to get better. Everybody's going to be better. I'm going to fix the world. We're going to change this thing. I'm going to make a huge difference. And then somebody ruins my day. And I'm like, sucks.
No, it's that's why we're all here to wade through these pools of uncertainty together. So, Megan, do you want to drop the prompts in the chat and I can get the breakout room set up? How big? We normally do like 5 to 6 per group. Is that a good number that you guys usually do, Quinn, Meg? Yeah. All right. Cool.
No, yeah, we're good. Go ahead.
I didn't realize I have all my quotes in the chat. This is exciting.
That was a pretty good one. All right. Well, so what? We'll break out for like 10 to 15 minutes and then we'll bring it back together and discuss gems. Okay. I said, so did you guys all solve anterior shoulder pain?
I think we solved it.
Chris, you didn't solve it?
Oh no, I did. If you just take the shoulder off, you can't have shoulder pain. It's quite simple, actually. I don't know why I didn't think of this.
But phantom limb pain is a real thing.
Don't ruin my. It wouldn't do.
I'm sorry.
Don't ruin that, Heather.
So any good discussions to share? We definitely had some, but I would love to give the floor to others first if felt like your groups were talking about something worth sharing with everyone.
We had a good discussion. Nathan and Jeremy and Yuri and Ben and myself. A lot of it came down to kind of the conversations that we're having with these particular patients, and knowing that they've probably heard several different opinions, several different, maybe not even physical therapists or rehab professionals, but also, the physicians and the surgeons potentially, if they're coming to you kind of second to prepare for the surgery or whatever to see. So it was kind of making sure that we understand where they are in terms of their thoughts about a surgery, or their thoughts about their condition in general, their thoughts about what they've been told from other practitioners, what they've potentially read on the internet, really getting a feel for where they're coming from, instead of seeing that they're in the pipeline for a subacromial impingement or a subacromial decompression, and then immediately just vomiting all of your knowledge about the current evidence, which is probably really good evidence, and it bolsters your confidence in what you would not recommend necessarily. But it just came down to really getting to know the person so that you could have these difficult conversations, and they'll be willing to listen to you and trust you, versus, putting up a wall if you're kind of like pushing back on what they had thought would be their fix.
Making it rain RCTs on them. So I guess to that, this was something we spoke about, which I think is an interesting talking point. Based off of this paper, the prognosis is fairly long in terms of recovery. So, how are you able to like navigate that healthcare encounter and that conversation where you're being transparent with them while also, you're being realistic, and you're also trying to get them to feel, optimistic and empowered about the recovery, but knowing it's a long haul. So like, what are strategies that you might do in terms of like short-term goal setting, or what you do want to focus on or not focus on, in terms of getting them kind of, engaged in the process, so to speak? Because I think that's like one of the ultimate challenges with this presentation in particular, is how are you having that initial conversation where you're trying to get them on board and be honest, but recognizing that it's probably a little bit of a longer prognosis.
Expectation setting in something like this is higher on the degree of difficulty.
And, just to share what we had spoke about. So Amit, was saying, trying to really, which I very much agree with, but in this short term, especially for this cohort, right? Because then we talked about, how does it differ with return to play for athletes, where it's going to be, in my opinion, a much different conversation potentially, with more of this kind of like general population cohort, age 35 to 65. Like, our initial goal is like, how can we help them re-engage with very meaningful, valued activities, and really start to get back into those things, understanding that hurt doesn't equal harm, and giving them a framework to kind of navigate through some, undulations in their pain. So that's really like where we talked about we would go with this specific cohort in terms of like short-term goal setting, is really trying to focus on getting them back to doing the things that are super meaningful to them, and hopefully things that involve physical activity. But then we were kind of getting caught up in how this would differ with an athlete that is trying to return to play ASAP, and they're dealing with this. Like, how the hell do you have this conversation? I think is really humbling and hard to kind of think about, knowing the prognosis.
So for me, one of the things that I do fundamentally, and I do this with every patient, regardless of whether it's shoulder pain or not, but I think you have to explore and interrogate them a little bit into what their current beliefs are, what makes up those beliefs, where are they, what's been told to them already, because I'm sure some of us have had patients where it's like, we want to say a thing, but you can tell that they've been so indoctrinated into a certain type or an expectation already that it's going to look like we are right, that we're fractured from this other person who they really trust, and now we're saying something that they don't really like, and now it's like, well, but I like Dr. So and so, and he said this, and now you're saying that you know more than he or she, then that's not okay. So I do think that before we say anything, you want to explore into them a little bit. So what like, you know, kind of walk me through the conversation that you had with Dr. So and so, or if you haven't seen a doctor, like, have you had this before? What'd you do about it? How did you kind of work through it? Or to get a better understanding psychologically of how they perceive this, so that I can be that car salesman and navigate towards that their already existing biases and kind of sprinkle my little flair into it is my thought, so that it seems more like Inception, right? Like, I mean, I'll certainly be Leo in this analogy because duh. You know, like I want to create their idea. I want to implant an idea into them so that they're like, oh, this is how I want to do it. And I'm like, oh, what a great idea. That's how I go about it.
No, it's an interesting question that I've used more often in the last year or two is, and every once in a while, like you sort of have to read the person, because sometimes they'll look at you like you're like a little crazy, like you're supposed to be the one telling me what I need to do. But I've asked some people with pretty good feedback and results, something along the lines of, what do you feel like needs to happen for you to feel better, or for you to like be successful in this venture, particularly those people who have tried other things. And then sometimes if I get a fully blank stare, I will say, well, because sometimes that happens. I'll say, well, you know, like, you know your body, you know what you've tried before, you know what you actually really believe, and I'm just meeting you today. So I want to heed that. I want to take that into my consideration. And sometimes people are like, they really honestly don't know what to say, but they're pretty appreciative that someone actually asked them that. But that sort of like what you just said, sort of reminded me of like, it's interesting literally to just get people's thoughts on what they think is going on and what they think that they need to do. And if they honestly say, I think that I just need like massage, or I just need, you know, stim or something like that, then that, if nothing else, that clues you into A, what you're dealing with, and B, how you might have to potentially modify things to meet this person in the middle halfway, because you guys might be on way different ends of the spectrum. And if you're going to be successful with them, you can't just fully just stick your stake in the ground and be like, I'm not going to do A, B, C, and D. Mm-hmm. You need to go find someone else. Sometimes that might happen organically, but
right. But it's like, I'm not going to use the word rotator cuff tear unless they've already heard that word, if that makes sense, right? So I want to know if they've heard that word, so that I need to diffuse it, hopefully with some magic, witchcraft, and some statistics, hopefully, if they're down with that. But I'm not going to bring that up. If you came to me and have not seen somebody that's told you that you have a cuff tear, I'm not going to bombard you with statistics about cuff tears, because that's irrelevant. And that's a buzzword that I don't even want to bring up. You have shoulder pain. That's a totally different thing than saying the big bad tear word. So that's why I want to find out what their preconceived notions are, so that I don't kind of step down this pathway of like, oh shit, I said the word tear, and now they're like, I knew it was torn, I just knew it. Oh, great.
Well, then if you can come to like a common ground of what success means, because a lot of people have never been told, you know, it's either get this or get this, don't do this or don't do that. They haven't necessarily had somebody who's willing to kind of be in the middle with them and guide them kind of through the ups and downs of the process. So if they may just think that any type of pain equals, you know, a failure, but if you reframe that, would you be okay with, or would you consider success? What if you could, if we got you to the point where you could do the things that you want to do at said level, and we'll talk about what that is, but you still kind of maybe felt your thing sometimes. But the difference being, you go through this process with us, and you have a much better system of managing. You understand what the ups and downs can mean and what you can do about them, and you can do the things that you want to do. You just kind of deal with your thing every now and then when it pops up. If that was the scenario, would that be success for you? And when I pose that question, the vast majority of the time, people say, yeah, that would be fine. But they don't know that that's even an option. They think like, if I'm feeling the pain, I can't do those things, and or I'm not ever going to be able to do those things again. So it's trying to sprinkle in kind of like the expectations of this prognosis, of the fact that this might be a thing that you feel every now and then for the future of you feeling things. That's kind of how some of these things work. But if you can frame success with, whereas that's maybe a piece of their puzzle, but it's not a big deal anymore. It's something that they can manage. Whereas now they're seeing you because it's become unmanageable. I think maybe that's where that's the difference of like regression to the mean. Well, I've had this thing for 2 years. You're saying I could just like, when does the regression to the mean start? That's those conversations they don't go well when these pain patterns have been going on for so long. And they also say, well, I have been active. Being active is what hurts. Like this is paradox. So the difference is you're going to kind of identify the nuance, and you're going to guide them, through these ups and downs, instead of them just like being lost along the way. And yeah, so I don't know where I was going with that, but
I know we had a talking point kind of on the other end of more so leaning towards surgery, more along the lines of, if you are kind of like that 18 months to 2 years, where, if they have been working with somebody like us who has been advocating, more of the educational side, doing exercise, trying to get them back to the things that they do enjoy, that it's still our job to let them know that just because we go the surgical route doesn't mean that you're going to fall apart or that things are going to get worse. Because I do think at times we read these studies and we look at surgery being like this big bad wolf that, well, if you get surgery, like we're in trouble. But I mean, at the end of the day, with this study, the surgery may not be addressing like the anatomical issues, but people are still getting better in the end. So if we're still addressing it the appropriate way with these people, and they're ultimately sold on surgery, continuing to give them that education and support them and let them know that, we can still get to where we need to be, even if this is the decision that you make, I think can also be important. Because at times I feel like we get too far on either spectrum, where it's you either have to get the surgery or you're in trouble, or if you get the surgery, you're in trouble, instead of kind of walking them through these decisions. Because ultimately, no matter what I say to a patient or I want them to do, I mean, it's really going to be up to them to decide what's best for them.
Heck yeah. Kind of going off of that, Tony had asked a question in the chat. Is there any situation where you would advocate for getting a subacromial decompression?
That's a really good question. I think there's going to be positive outcomes at some point with this. I mean, the concern, like I think if you can truly demonstrate that this is a structural deformity that has and/or responded, in some way over time and adapted to the point that it's become an issue. Yeah, I think and again, I think people have had successful outcomes too. So you could argue that, well, then those were the people that should have got it, right? It's easy to say, well, yeah, those are the ones that needed it. I mean, personally, I don't typically advocate for that surgery unless it's a thrower, and on their throwing shoulder, they have this type of scapular coracoid deformity. Acromial deformity. That's the only population that I've seen and spoken with surgeons, and they say, like, this is something that we see very successful, and that's in throwers or swimmers or overhead athletes with this deformity.
Yeah, I think that.
I'll,
Sorry, go
you
ahead.
go, Chris. No, you go.
I was just going to say there's probably a difference too between advocating for it, as in like this is something you should potentially do if you're presenting with XYZ, or if this is part of your history, versus somebody who's going to get it and the way that you educate from that. So like if you're going to get an ACL reconstruction versus not, you have that conversation. Well, what do you want to get back to? Do you want to get back to level 1 sports at a collegiate level? You're going to maximize that likelihood if you get the surgery, most likely, at least in the constrained timeline that you're in, you know, college and these types of things. But with the subacromial decompression, there's not a lot to have that conversation with. There's not, well, you know, what do you want to get back to? If you want to get back to XYZ, you should probably have this surgery. Save potentially for a case like what you just mentioned, Chris. Like that's the kind of stuff where we have to start really increasing our resolution in regards to how we're subgrouping certain populations for these types of things. But that's not how this surgery was founded on. So it's hard to.
Right.
Yeah, Quinn, I was just going to add, you know, I think advocate was kind of the word that just tripped me up, because like, I don't know that I would necessarily be like advocating in the sense of like, yes, you should definitely get this surgery. But I do think, and I know because I literally lived through it with this case study I was sharing you with, where, you know, if an individual has been working through rehab for 2 years and they have made no improvement whatsoever, and they were identified with having a type 3 acromion, and surgery was something that they were wanting to try, I wouldn't be dismissive of it. And I wouldn't be like, no, it's not going to work. So I think I would be more like, you know, I think that's reasonable to want to explore that option. And if the surgeon thinks that it's something that could be positive, like I'm all for it if it's something that's meaningful to you. So I don't know if that makes sense, but I don't know that I would be like trying to sell it as the fix per se. So it's kind of a tough, I don't know, it's like a tough thing.
It's just like a gestalt. It's a feeling. Like if it's the person who's come in with just like 3 months pain onset and no other history, and they're like, should I get this subacromial decompression? We're probably much more like, we'll pump the brakes a little bit. But like you said, Zach, if you've been working with this person for 4 months yourself, they've been dealing with this thing for 3 or 4 years already, there's been no change, it becomes this, there's a shift, and it's just like, well, and the conversation changes, and we don't have, like for this in particular, we don't have like tests and measures and certain normative values to tell us when to have that conversation. It really is just so dependent on the person.
Heather, did you have a comment that you want to unmute?
Oh, it was now a couple comments back, but I was just going to say, even less specifically to this specific surgery, but back on the question of sort of recommending surgery in general, I think not in this group of people, but in the general population, surgery is very much perceived as like a solution. So I'm having this pain, I will get this surgery, and then everything will be super great. Versus I think it's almost more of a question of reframing, like surgery is a tool that could help us that could help, this specific issue, usually, combined with these 7 other tools, versus do I get this surgery and be like cured, so to speak, or do I have to do all this other hard work and not end up getting this surgery, and which ones, and sort of a reframing of surgery in that sense, that it's not like, it's just a tool. It's not a solution per se.
All right. Any final closing thoughts? What we'll try and wrap up in the next 5 minutes. or now. I don't know what the vibe is. It's been a very good conversation. It's been helpful for me to sort through some of my own
It's been
thoughts.
exhausting, clearly.
Yeah. Penny couldn't take it anymore.
An exhausting conversation, really. Oh.
We just dropped a link in the chat for the post-meeting survey for people to fill that out and give us feedback, how we can make these better for you guys. Zach and Steph, thanks so much for being the lead.
Thanks for hanging out with us on Friday.
Friday night nerd sessions are one of our favorite things, so this was great. So thank you everyone for hanging out with us, and very much looking forward to next month.
We'll be bigger.
Yeah. See y'all in the Facebook group.
Good night, everybody.
Night.
All right.